Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
And we're here.
We are. So are you.
Yes. Well, let me tell you who you are. Who we are. I mean,
let me tell you who you are.
Let me tell you who you are.
You are a person who knows good quality YouTube.
You know good entertainment.
Entertainment when you see it.
Edutainment.
Edutainment.
Information.
Infotainment. What is
that?
There it is right there. Are you not entertained?
That's how it starts.
Are you?
Okay. That was a stage sneeze.
Yeah.
Well, we need to talk about...
Wait, sounds like we're...
Inappropriate healthcare.
Sounds like we're having an intervention.
Somebody's been inappropriate. Someone out there has been inappropriate. And we're gonna, and we have people probably being inappropriate on the chat. We have people on the chat.
Please.
So let's bring up the chat. Here we go. We have, all right, I'm going to tell you 6 words and you have to remember them for 3 minutes. The 6 words are, do you remember them?
Divine spirits.
Divine spirits. Tacos.
There's TV in there.
Girl messages TV.
Ah.
She's clapping hands for us. She's glad that we're having the show. And she also says, I'm assuming it's a she. I could be wrong here.
It's
Hi,
girl.
friend from New Orleans.
That's
God bless you, by the way. Yes, and you also. Thank you, Divine Spirits Tacos Girl Messages TV. Lindsay Antwine says, going to do my best to refrain from being inappropriate. And we just laugh at her. We just laugh. Okay, we have Sheila Davis say, why did I receive this? I don't know. What'd you get? Oh, you mean like a recommendation to watch this show? It's because YouTube has decided you have great taste in videos.
Yeah.
That's fine. Tojo or Toho, I'm not sure. Hiya, watching from England at 0031.
That's past my bedtime.
I am so sorry you have to stay up to watch this show live. But
so obviously, we're going to put you to bed, to sleep. Because we are so...
Just turn us on, and as we talk about inappropriate medical care.
This is not an ASMR thing that's going to put you to sleep. Sorry.
Hilda Bauer has an emoji of some sort. You guys can see it. You tell me what it is. And then we also have LS saying aloha from Hawaii. Boy, people all the way from England to Hawaii are watching right now and commenting. And New Orleans. This is awesome. Lindsay, or is this episode my free pass to indulge my... Oh, gee, I'm getting uncomfortable.
That sounds like every...
And Hilda's telling us that she's from Dallas, Texas. We have the 4 corners. There we go.
We've got it kind of. Yeah, New Orleans, Dallas. We've got it all covered.
England.
Wait a second.
Okay, the New Orleans, Dallas, they're kind of close together, but oftentimes we have somebody from Canada.
Yeah.
Do you remember who?
No.
Is it...
Man.
Is it...
Do you?
I'm working on it. Is it Laura Barzyk?
Who's from... That could be right. I don't know.
Or is she just from northern U.S.?
Don't know.
Okay.
Anyway.
So we're talking about inappropriate medical care. There was a Kaiser Foundation, KFF? Kaiser...
Family Foundation, right?
Kaiser Family Foundation had a study on inappropriate medical care, and I read the first paragraph, and then...
Now we're experts.
And then Monday. And now here I am.
And then Monday happened. So it was a Monday.
Oh my goodness. Yeah. This was, wow. I don't know about your day, but you had the same lunch hour I had, so I know
I did.
I know you experienced that
part. Yeah.
We're still working on that.
Tell 2 people that their licenses were not.
Driver's license.
Yeah.
That.
They revoked driver's licenses. Oh man, that's tough. Hard
So,
part of the job.
And I also interacted with a patient whose husband doesn't have, and he's my patient too, doesn't have insight into his illness.
Oh man. Yeah.
And it involves knowing what's going on.
Yeah.
And those are really hard situations when you're working with a patient and they don't see what you see and what's objectively being measured.
Right.
And they're like, no, that's not the case.
Right.
Everyone else is in agreement, including your family members who live with it.
Yeah.
Yeah. So that's a hard one to have to act on, in the patient's best interest for their health and safety, and they don't
which is appropriate
They can't
medical
see it.
care.
And,
Look at that segue
and if
into inappropriate.
inappropriate medical care. So, do you know what inappropriate? Do you know what it was talking about?
No, I didn't read this
Oh, you don't
article.
even know. Okay.
I had a Monday.
Well, I didn't read it a little bit further than you, or
Enough to have
I
a
did read it
conversation
further
about
than
it.
you.
Yes.
okay.
I just show up here.
So yeah, you did an awesome job with the GERD discussion. You didn't even know what it was and just rattle it off. That's a good show if you want to learn about gastroesophageal reflux disease. The one where Dr. Gawain just gives the whole lecture just off the cuff, no prep, and he just nailed it. It was great.
Sometimes.
So the inappropriate medical care is talking about those things that are done that medically there's no indication for it, or the data is so poor for it, or actually says to do something else that it's not the right thing to do, and yet lots of healthcare dollars are being spent on this sort of thing. So one example is upper respiratory infections being treated with antibiotics.
Right.
Another one would be excessive imaging. That's quite
testing is what I immediately went to.
As Dr. Gaskin would say, MRIs on knees on people over 50.
Yeah. Complete
She's a little
blood
extreme.
Panels every year for your annual.
The so-called executive panel. Yeah, every year, even though the person has nothing that
No reason.
Yeah, no indication
Congratulations,
for
it's
it.
all normal. Oh, I found something abnormal. Let's do more tests to find out that it means nothing.
That
and
it was
costs a lot of money.
That's the thing. When the accuracy of the test you're using is not 100%.
So there's this thing called pretest probability. I think that's where you're going.
We've done this on shows before, so some of you may have followed, or maybe getting a refresher, you'll get it this time, because I remember medical school, this was a tough one.
Oh, yeah. It's hard to wrap your mind around that the likelihood of finding an abnormality affects the likelihood of that abnormality actually being abnormal. Does that make sense?
Not the way you said it, but I know what you mean, because I followed it.
Okay.
See?
But it's, it is hard
that's
to follow.
the principle.
There you go. You got it.
Yeah, something that you get certain percentage results positive, certain percentage negative. Well, depending on who you choose ahead of time to do the test on, those numbers are going to be different.
Right. Yeah. There are some things where we actually will run something through a calculator or try to figure out a true pretest probability. And then figure out what test to do based on that. The classic one that comes to mind is DVTs or PE, pulmonary embolism. And
Blood clot to the lung.
Yeah. So we actually have a scoring mechanism based on presentation and risk factors that you can run them through, and it says, okay, then you should probably do this test, or the likelihood is this high, so we go this direction, which is kind of neat.
So the things that give you the score are things that you get from just simply looking at and talking with the patient. Mm-hmm. And then from that, you develop the score. Like there'd be a point for chest pain or shortness of breath or fast heart rate or maybe EKG changes might possibly be included because we can do EKG.
Recent travel or surgery.
Medicines you take or don't take, maybe.
Yeah.
I don't recall myself. The Wells criteria, is that what you're talking about?
Yeah.
I'd have to look it up, which, we have wonderful things like
that's why we have MD
Calc and
like
that you can just
make it really easy.
You don't have to memorize it anymore. You got MD Calc for it. We live in a wonderful age.
Or like a strep test. Hey, there's one that you probably know, the Centaur criteria. But anyways,
I think we've been on the show before.
Yeah, we've talked about that. But those get into appropriate testing or appropriate use of antibiotics.
So once you do the scoring on the patient, you get this recommendation for, use this super expensive test or use this intermediate expense test that might not be accurate on either the sensitive part or on the specific part. One of them means missing when it's there and it saying that it's not, or saying that it is there when it isn't. Those are both errors on either end of the spectrum, and sometimes one matters more than the other.
Right. Yeah. Sometimes we want to not miss something, and so we'll group a lot of people in that may not even have it.
Yeah.
Sometimes we have stricter criteria.
So hold that thought while we check.
I'll hold it.
Your comments and questions, because you're such a wonderful audience. Okay. Angela H. Hello, doctors from Atlanta. I'm not on the.
Where are we at?
There
it
we go.
is.
Yeah, there she is. And then Divine Spirits Taco Girl Messages TV says, I clicked off Dr. Miami to come chat
excellent.
over here.
I have no idea who Dr. Miami is.
But we feel honored you would choose us.
Doctors in Auburn are way cooler.
Dr. Miami. What is inappropriate medical?
Yes,
We're
great
going to
question.
get to that. David, I just left the hospital after 3 days of
MRI, CT, Ultra.
MRI.
There's a dot in between those.
CT ultrasound test.
Oh,
3
so
days
three
of-
different
okay.
things. Okay.
And then, David, I understand ruling out. Yeah, that's a term we use.
We sometimes
And
use
did
it.
I hear the phrase centaur? Centaur.
That's what I'm calling it from now on. Absolutely.
Oh, my goodness.
So it's a guy's name, Centaur, Centor. But Centaur is way better.
The centaur criteria. If the person has hooves, they get a point.
Yeah, they get a
That's
point.
the centaur criteria.
The Centaur criteria.
Nice. Angela, I've never questioned my doc's tests. Maybe I should.
I'm happy to answer any questions I get and from my patients about why I do certain tests or why I don't do other tests.
We've got reasons for it.
It's funny that you mentioned things that healthcare dollars were going into. So that really specifically talks about things that doctors are ordering. But there are things that happen outside of the medical system that you shouldn't be doing too. A lot of these, like, come get your ultrasound or come get
there's
your
no end
whatever
to it.
testing.
Yeah.
Some of them
Line screening.
Yeah. Most of those are not recommended for various reasons. Again, it gets into pretest probability and things like that, and the likelihood of false negatives. So,
And your insurance will probably pay for it if it's actually
if it's appropriate,
your-
absolutely,
through your doctor.
right. So don't go out and spend the $100.
Well, they have different tiers. Like
Whatever it is.
Yeah.
Probably more now.
And at the same time, there's all like genetic testing. Do your own genetic testing for disease, and
It reminds me of I
What are you gonna
remember
do
we
with
had
it?
that
What are you
discussion
gonna do
about
with
that one patient who was going through a certain protocol. I don't necessarily want to say the name, but was paying, was it $5,000 a year on this protocol and all these things to try to prevent dementia. And then we looked at her numbers, and she just had this decline, like she was getting dementia.
yeah.
It was unfortunate.
I think we tried to talk the family out of that.
Yeah. I've had multiple conversations with them.
Yeah. And that was actually a medical doctor was one behind it.
Yeah. Using a guy's from UCLA. They were even using the name.
Yeah, because he did some work there related to dementia, and then just went off the rails with what the results of his actual study was, and then took it to an extreme. Right. I don't think with the institution's blessing.
Probably not.
Yeah.
I wouldn't think so. But the big takeaway is I hope you have a trusted primary care doctor that you can sit down with and one that has your best interests at heart. We
and a lot of these
and most of us
recommendations that we're talking about,
a lot of good doctors out there,
are available freely on the
internet. You can look them up.
Yeah, you can look at
what you do
AFP
for
guidelines. You can look at guidelines from the NIH. You can look at guidelines.
USPSTF.
Yeah. It's not hidden.
Yeah.
Well, it is hard to. It's even hard for me to look up sometimes.
Sometimes it's hard to tease out what you need, and what those recommendations are, and they give these letter grades to what's an A recommendation, absolutely get it done, versus some of these lower recommendations that have certain criteria. So,
yeah. Okay. We have more comments, so that's why.
Absolutely. Let's answer more questions. Hopefully, we have some.
We have David asking, but when it has been established, primary. I'm sorry, that's not a sentence.
I think it was related to the
why don't
ruling out.
I think we're supposed to go on to the next one. Why don't they tell you clearly what they are going to do instead of keep referring you to more testing? Oh, I think I might know what he's getting on there.
Okay. Because
when you got not giving the patient a clear answer as to what's going on,
like why we're getting into the next test or what we're looking for.
So we try to, at least in our office, give a basic explanation. We don't want to go down too detailed into what all the different things are, but you should have a general idea. Like, we want to make sure it's not cancer, but you have to be really, really careful doing that, because some people, once they hear
the word cancer, they don't hear anything else.
Yeah, their ears are stopped up or chopped off or whatever, because nothing else gets through once you say that cancer word. And so you want to be real careful about saying that that's on the list of things you're looking for. But you know, oftentimes it's like cancer versus infection versus stroke. You know, if it's
versus benign growth.
You know, neurologic benign growth, right?
Yeah.
So, but somebody should at least go through a very general list with you, maybe just by phone message if that's all you can get from them. We do encourage people to at least have a basic guidance as far as why more tests are being done when a test comes back and it's abnormal and, we need to follow it up.
Yeah. I prefer doing that like in a visit, especially when it's something important.
That's
like,
we want to do it
we need to biopsy this, or we need to move on to that next step of like a PET scan or something like that. It's much easier to have that conversation than to do like the online typing back and forth.
Back and forth.
Even a phone conversation can be a little hard to talk about that.
Yeah. Most of these things, if you have a real concern and whatever it is that's going on requires more testing, then it deserves to have some discussion.
Sure.
And some doctors might be comfortable doing that over My Health Online. I know I don't want to get caught in a situation of a 2-entry My Health Online coming through, you know, because you're limited how many words.
Yeah.
And I'm trying to get through my inbox and trying to get that done so I can see the patient that just got roomed.
Mm-hmm.
You know,
and actually, that gets into the conversation of appropriate testing in the elderly. You know, if somebody is older and has a fairly short horizon in front of them, it's worth having that conversation on how in-depth you want to go into this testing. You know, if somebody has a year or two of life left just based on their age and frailty, you probably don't need to do all that in-depth testing,
especially if
to find something, especially if you've had the conversation and said, okay, I don't want any surgeries. I don't want any chemotherapy. And that's a good conversation to have. And sometimes if you go down that road without that conversation, it can be inappropriate.
Yeah. Especially when, how much will the treatment get me? Well, what's your life expectancy? And not expected
not much beyond that. Yeah. And it actually may cause those years that you have here to be a little more debilitated from the side effects of treatment.
Right.
Yeah.
We also have a comment from Angela H. I have fibro and arthritis, and I never know when X-ray is required. When is a back X-ray?
Good. That's a good question.
Once.
Yeah. So back X-rays are kind of in their own category, I would say, because a lot of people will, quote, throw out their back or do something. And if it's just that...
You really shouldn't throw out your back because nobody's going to give you a new one, so keep it.
Don't throw it. Keep it, yeah. But anyways, you'll injure your back sometimes after bending the wrong way or wake up that way, or, we don't have a cause or a reason. And without what we call these red flags or scary signs, you actually don't need to get a back X-ray because most of those, trauma, history of cancer, certain neurologic signs in the legs, you don't need to get an X-ray because most of those will return to normal within 4 weeks.
So don't get mad at your doctor for not getting imaging,
please,
for mechanical low back pain.
Yes.
Because they're doing the right thing.
That's the take.
That's appropriate.
Yes,
care.
That is appropriate.
Because the vast majority of people will get better. Those who don't, as long as you check for those red flag things, ask the 4 or 5 questions, whatever it is. As long as they go through those things and the answer to all of them is no, the appropriate care is don't get imaging at the first visit. Do some physical therapy or do some therapy on your own. Maybe take anti-inflammatories if the person has normal kidney and can take them and isn't on medicines that keep you from having them. And then follow up in 4 to 6 weeks and see where you're at. And maybe at that point, some imaging would be ordered. Again, you're not losing something by not having done it back at the first visit. If it didn't get better on its own. Okay, so we actually caught up with the comments and questions. Some of the most common things for inappropriate care: antibiotics for infections that don't respond to antibiotics. And it doesn't mean it is or isn't bacterial. It means you just don't make the patient significantly better by giving the antibiotics. One of the things coming up, we're really going to be acutely aware of it, January 1st, when Paxlovid costs $1,500 a course.
Right.
We're going to be running into an awful lot of, I got Paxlovid last time and I got better. well, you'll probably get better this time too.
Yep.
Just as if the Paxlovid
Yeah.
hadn't been given the first time. So do expect that. If you're a healthy person, you're under age 65, and your insurance probably won't cover the Paxlovid.
Right.
Don't be disappointed. You'll still get better.
Yeah. Yeah.
For most people.
For most people. Yeah.
Yeah.
There are high risk
Especially if they got
people
their shot.
where it would likely be
We
appropriate.
still
who
encourage the
should
COVID shot. We do.
probably get their vaccine as well.
Yeah.
Yeah.
Okay, so that will, and then Angela H. thanked it. Wow, thank you. Somebody thanked us. That's really nice. We appreciate
You
that.
are welcome.
We really appreciate those folks on Patreon because
Yeah.
we're able to get a Dutch Brothers before the show because of their generosity. So we really thank you for that. We changed up the list at the end of the show here to match what's on Patreon. So you'll be able to see that. And if you wanted to have your name there, you can too. Instructions are at patreon.com. The link will be in the description. Anything else you wanted to throw out there?
I don't think so.
Okay. So,
Is there something else I need to
no. So until next time, I'll take that off.
Hey, I'm Dr. Wayne Vaughn.
Dr. Mark Vaughn telling you to stay in good health.